Chalo, partograph. Partograph is very important. You also slept off in my class. You also, oh my God. Okay. Chalo, coming back to partogram. Now, partogram, what is partogram? Partogram is basically a graphical representation of the events in labor. Okay. Now, what to understand and what comes in the exam, this we have discussed. A little bit of history, may we know that first active stage was said to be at 3 centimeter, then 4 centimeter, and now 5 centimeter. So based on this, over the last few decades, different partographs were there. First was this WHO simplified partograph, then came the WHO modified partograph, and now is the labor care guide based on these cutoffs for active labor. Okay. So, but we will be discussing two partographs. This has not been followed for many years now. The WHO modified partograph was being followed till 2018 when the लेबर केयर गाइड गॉट इंट्रोड्यूस्ड. तो बहुत सारे हॉस्पिटल्स में अभी भी ये फॉलो होता है. ठीक है. एंड इसलिए इस पे क्वेश्चंस आते हैं बिकॉज मेनी ऑफ द ओल्ड क्वेश्चंस इन द क्वेश्चन बैंक आर स्टिल बेस्ड ऑन दिस. However, this is new and it's not very new now. It's being followed in many medical colleges in India now since 2-3 years. So a lot of new questions can be expected to be asked from here also. So you are the batch, you and the batch, maybe next 1 or 2 batches after you are the batches which should know both the partographs, unfortunately. ठीक है. एम्स में फॉलो हो रहा है. All the medical colleges in Delhi are following the labor care guide. All the top medical colleges in India are following the labor care guide. So it is very possible that questions will come from here. But because the old question bank is still has questions from here, तो दोनों expected है. ठीक है. Now, so let's first discuss the WHO modified partograph. Okay, so I'm not showing you the whole partograph. I'm just showing you the most important part of the partograph, that is the cervicogram. This is the cervicogram. This is cervical dilatation. ठीक है. Cervical dilatation versus time. ठीक है. Now, in this, you need to understand that cervical dilatation, the WHO modified partograph is based on active labor starting at 4 centimeters. It is also based on that the rate of cervical dilatation in active labor is 1 centimeter per hour. Okay. So you start plotting it when the patient enters active labor, that is 4 centimeters, and it should follow this basic minimum 1 centimeter per hour. That means if the patient suppose comes at 9 p.m. okay, and she's 4 centimeters, so I'm going to put plot here. She suppose after 4 hours, so 9, 10, 11, 12, 1 o'clock. At 1 o'clock, if I repeat a PV, I find she's fully dilated. So I'm going to plot my mark like this. So this is the cervical dilatation. So anything to the left of the alert line. So there's this line called the alert line. This alert line is plotted at the rate of 1 centimeter per hour. Anything which is falling to the left of the alert line, I am happy because this means cervical dilatation is progressing normally. But suppose after 4 hours, I do a PV and I find that she is, so say 7 centimeters. So my plotting will come here. So now this patient has crossed the alert line. What does that mean? Now I have to be alert. Something is wrong. Labor is not progressing normally. So I have to check my 3 P's: passage, passenger, and power. And what else should I do? I should also, this is also called the referral line or the transfer line. This is the point where if I am sitting in a place where I do not have emergency obstetric care facilities, this is the time I need to refer the patient to a higher center. Okay? So this is the alert or the referral line. Suppose after another 4 hours, suppose this patient was, I checked everything, सब कुछ ठीक लगा, so I give her another 4 hours. So I check now at 2, 3, 4, 5. At 5 o'clock, I find she is only 8 centimeters. That means she is here. Okay. So now she's reached the action line. So if she goes beyond the action line, I need to take action. That means I need to urgently deliver her, because this is a point where delivery should now be done. Action should be taken. Right. So this is, once you cross the action line, you have to be very, very worried and deliver her. So this is the WHO modified partograph, which basically says that the alert line is plotted at 1 centimeter per hour. You start plotting at 4 centimeters cervical dilatation. Okay. Anything to the left of the alert line is normal. Anything between the alert and action line, you have to take corrective measures. Anything to the right of the action line requires urgent delivery. ठीक है. Alert line is called the referral line. ठीक है. इस पॉइंट पे आप रेफर करोगे. अगर आपके पास सिजेरियन सेक्शन के फैसिलिटीज नहीं है, you're going to refer the patient to a higher center if it crosses the alert line. Also remember, another important point is that the first marking is always on the alert line. What does this mean? This means that, so let me just clear this. The first marking is on the alert line. What does that mean? That means that suppose a patient comes to me and it is now 9 o'clock and my resident calls and says कि ma'am एक patient आई है, she is 5 centimeters. So will I mark this patient, this is 9 p.m., will I mark like this or will I mark like this? पहला वाला ठीक है या सेकंड वाला ठीक है? सेकंड वाला ठीक है. वेरी गुड हिमांशु. सो आई एम गोइंग टू मार्क लाइक दिस. एट 9 o'clock she has come, she is 5 centimeters. So the first marking is always on the alert line. Why? Because इससे पहले वो कितनी थी मुझे नहीं पता. Patient has come to me now. She might have been 5 centimeters for 4 hours or 6 hours or 8 hours. I don't know. Right? I do not know how her progress was before this. So I presume by starting on the alert line कि अब वो 5 centimeters है. अब इसके आगे देखते हैं कि she crosses the alert line or doesn't cross the alert line. So that's another question which is important. This has come as a question. Another thing, if you look at the bottom wale boxes, so this is time. Each big box is 1 hour. Each small box is 30 minutes. Another part of the partograph you see here is descent of head. Of descent of head, one way I told you, you check the descent of head is the station, -3, -2, -1, 0, +1, +2, +3. But partograph में हम ये वाला descent नहीं देखते हैं. We see the descent based on the second pelvic grip. That means on the pelvic grip. That means on seeing how much fifth of head is palpable. Fifth of head palpable is checked. What does this mean? So look here. So you have 5/5, 4/5, 3/5, 2/5, 1/5, 0/5. So when the head is high up, all my 5 fingers, when I'm doing the fourth Leopold maneuver, all my 5 fingers can touch the head. But as the head starts entering the pelvis, less number of fingers can touch. पहले 4/5 होगा, फिर 3/5 होगा, फिर 2/5 होगा, फिर only 1/5 of head is palpable. So as the head enters the pelvis, less number of fingers can palpate the head. So when the head is completely mobile, the head is 5/5 palpable. So suppose the patient came at 5 centimeters and on abdominal examination, the head was 3/5 palpable. 3 of my fingers could palpate the head. I would mark it like this. Okay. If the head is no longer palpable per abdomen, that means the head is 0/5 palpable. Okay. So the descent should go like this and the dilatation should go like this. So descent of head is seen in terms of abdominal examination, not in terms of station of the head. Simple. Okay. And yes, somebody is asking engagement पे head कितना palpable होता है. On engagement, the head When the head is engaged, that means the vertex is at 0 station on doing a PV examination. The head is at the ischial spine. जब engagement बोलते हैं ना, the vertex is at 0 station. At that point, the head is around 2/5 palpable. Okay, this is a little controversial. Some books will say 1/5 palpable. So 1/5 to 2/5 palpable is the head at engagement. And when you do a PV, it is at 0 station. Okay, this is on abdominal examination. This is on vaginal examination. Now I put some pictures here. This may not be in your workbook, just to show you how the old partograph was. This is the WHO simplified partograph जो 2000 के बाद use नहीं हुआ है. इसमें can you see latent phase was there. So this is the WHO simplified partograph, ठीक है? And in this latent phase was there, but this is no longer used. उसके बाद आया the WHO modified partograph, what I just discussed with you. So I just discussed this part with you. This is the WHO modified partograph. Okay, and in this you have many columns. You have fetal heart rate, amniotic fluid, molding, the cervicogram, then contractions. So बहुत कुछ है, but main focus is on the alert line and on the action line, and cervical dilatation starts at 4 centimeters. Okay. Now this is the new one. This is the labor care guide, what we will be discussing in a bit more detail abhi. Okay. Now coming to some examples, just come straight to the examples. This I think is there in your workbook. So just let's understand based on the WHO modified partograph, let's do these examples. Okay. A 22-year-old primary gravid, descent of head बच्चा is very simple to understand. आप जो Leopold maneuver कर रहे हो fourth वाला, उसमें you are facing the feet of the patient and trying to do an abdominal examination and seeing how many, whether your fingers are converging or diverging. So at that time, you see how many fingers can touch the head. If all your 5 fingers can touch the head, it is 5/5 palpable. But जैसे head अंदर जाएगा, less number of fingers will be able to palpate the fetal head. At a certain point of time, you won't be able to palpate the fetal head. Okay, as the head goes in, less number of fingers. Okay, because इतना head wide नहीं होगा. Head अंदर जाएगा, तो 4 fingers, then 3 fingers, then 2 fingers, then 1 finger will be able to palpate the fetal heart. It is not subjective. You can easily make out. Okay. Now, a 22-year-old primary gravida presents to the labor room at 38 weeks in labor. And also remember, as I said, engagement happens when the head is 1/5 palpable. Some books will say 2/5 also. Both are correct. Okay, I have gone through many books for this. Some will say 1/5, some will say 2/5. Datta puts it in between 1/5 and 2/5. Okay, and at this point, if you look at station, the head, the vertex is at 0 station. Okay. Now coming to this, a 22-year-old primary presents to the labor room at 38 weeks in labor. On examination at 2 p.m., she is 5 centimeters. So let's plot this first. So she is 5 centimeter at 2 p.m. And the head is 3/5 palpable. So the head is here. Okay. After 4 hours, that means 2, 3, 4, 5, 6. She is fully dilated. That means this is the partograph, right? So this is a normal partograph because it is gone to the left of the alert line. Everything has progressed fine and she delivers by 7 o'clock. She delivers. So this is how you plot a partograph. This is a normal partograph. Now let's go to a different scenario. A 30-year-old is induced for past dates at 40 weeks, 4 days. Okay. After 6 hours of induction, she is examined and found to be 4 centimeters. So at 1 p.m., this is 1 p.m., she is found to be 4 centimeters dilated. At 5 p.m., she is 6 centimeters. So 1, 2, 3, 4, 5. After 4 hours, she is found to be 6 centimeters. So she has crossed the alert line. And ARM is done. So probably the contractions were less. And ARM was done at this point, and at 8 p.m. she is fully dilated. So 6, 7, 8. So at 8 p.m. so now things have corrected. It has become corrected. She is now again dilating at a normal rate. Okay, so this is a normal partograph and she delivers at 8:15. Matlab initially it had crossed the alert line. Then what was done? Corrective measure was taken. What corrective measure was taken? Artificial rupture of membrane. That means probably contractions कम थे. ARM से क्या हुआ? Augmentation of labor हो गया. ठीक है. So basically once the line crosses the alert line, you have to look for a possible reason and if possible do corrective measures. ठीक है. Next question. A 24-year-old primary presents to the labor room at 39 weeks. At 6 o'clock, she is 4 centimeter. So let's plot this. This is 4 centimeter. This is 6 o'clock. Okay. After 4 hours, that means 6 o'clock, 7 o'clock, 8 o'clock, 9 o'clock, and at 10 a.m., she is found to be dehydrated. Uterine contractions are 4 in 10 minutes lasting for 40 to 45 seconds. That means she's getting good uterine contractions, but she's dehydrated. PV reveals she is still 4 centimeters. So if I plot now, I'm plotting like this. What has happened? Dilatation hasn't happened. This is a rest of dilatation. There is no dilatation. It has arrested. Despite good uterine contractions, dilatation nahi hua hai. That means there's possibly a problem in the passage or the passenger. What we call as cephalopelvic disproportion. What is cephalopelvic or fetopelvic disproportion? कुछ गड़बड़ है, या तो fetus बड़ा है या pelvis छोटा है. Some problem is there, है ना? Molding is plus, so she's going into obstructed labor. So good uterine contractions, but labor hasn't progressed. So what will you do here? It's reach the action line. You will do a cesarean section. Okay? So need to understand that once it crosses the alert line, you have to be careful, look for corrective measures. But once it's crossed the action line, then you have to take immediate corrective measures and deliver by the best way, which is a cesarean section. Okay? But now things have changed. So now I'm going to make it more confusing for you. Okay? Because अब WHO ने labor care guide introduce किया है, which has changed all the concepts I've taught you till now. Ab na, everything is changed. So let's try to understand this. This is how the LCG looked. It's very blurry, so I've split it into parts. Why the changes were made? Because it was found that everything was over medicalized. That means there were too many cesarean sections happening. Okay, the natural process was lost. Okay, and there was a negative childbirth experience in women. So to improve the experience, the childbirth experience, this was introduced. That was one reason. The second reason was the change in definition of active labor. So पहले जो 5 centimeters, जो 4 centimeters था, वो अब 5 centimeters हो गया. So they had to change it. ठीक है? And Americans तो कहते हैं ACOG says 6 centimeters, but we're not following Americans. We are following, अभी हम 5 पे ही है. अभी 5 को adjust हो जाए, फिर हम 6 पे आएंगे, है ना? So we are still in that change. We're trying to understand. But remember, 5 is the new 4. Now, WHO labor care guide is done in apparently healthy pregnant women. So low risk women, it is best done for low risk pregnant women. High risk women may require additional monitoring. Okay? And it should be started at 5 centimeters or more of cervical dilatation. Okay? Now, the structure of the LCG guide has 7 sections. ठीक है, इसमें जो main जो new sections है, which were not there in the old partograph, is section number 2, supportive care. This was not there in the old partograph. And section number 7, that is shared decision making. This was not there in the old partograph. So supportive care and shared decision making. What is shared decision making? is कि आपने कुछ गड़बड़ मिला आपको partograph में. What corrective measures have you taken? In the old partograph, this was not there. It's only there here. कि what corrective measures have been taken? ठीक है? Now let's understand. So I've just put 4 sections together to make it to make you understand better. Now look here. So you have the first is of course identification, name, age, and all that. Okay, parity. Now a new thing in the partograph is this. Look at this column here. This is a alert column. ये पहले नहीं था. This is something which is new. This alert column is new. So in all the sections, you have an alert column. What is this alert column? This alert column is telling you when to be alert. For example, section 2 is the new one. Na? Section 2 is supportive care. Does the patient have a companion? Okay. If suppose she has a companion, you write yes. Suppose the patient says कि मुझे companion नहीं चाहिए, है ना? I want to be left alone. Leave me alone. So you write D. D का मतलब declines. ठीक है? Suppose patient says नहीं, I want somebody to be here, but you don't offer her a companion. आपके पास है ही नहीं कोई साथ पे देने वाला, बहुत busy चल रहा है labor room. So it comes, you write N. N is an alert. Alert means you have to take now corrective measures. You can't not give a companion. You have to give a companion to the patient. Okay, so N is where you have to get alert. Similarly, pain relief. The patient can, if you're giving it, you write yes, 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 or D if the patient declines. But agar N aata hai, patient has not got pain relief, it is an alert sign. You have to give the patient pain relief. Okay. Then oral fluids. Oral fluids, अगर patient नहीं ले रहा है, it is an alert sign. Posture में you have mobile and supine. M मतलब you are happy, patient is moving around. Patient लेट गई है, तो आपने उसको लेटने नहीं देना है. आप उसको बोलोगे नहीं, चलते रहो, चलते रहो, चलते रहो, है ना? तो supine is an alert sign. ठीक है? Similarly, baby में क्या है? Baseline fetal heart rate. What are the alert features? If it's going bradycardia less than 110, or if it's going more than 160, it is a alert feature. Similarly, fetal heart rate decelerations. No deceleration is good, or early and variable are also all right. But L nahi hona chahiye. L is an alert feature. That means late decelerations nahi hone chahiye. Similarly, meconium and blood-stained amniotic fluid are alert signs. Occipito-posterior, occipito-transverse are alert signs. 3+ caput, 3+ molding are alert signs. ठीक है, तो ये alert जो column है, ये पहले नहीं था. It is something which is new. So this is there in the main notes if you want to understand. It's never been asked, but I thought it's something which all of you should know. So in the workbook, we won't find so much detail. But I put this in this class specifically just to make you understand कि exactly क्या चीजें हैं. ठीक है? So for example, these are the abbreviations for companionship. Yes, no, woman declines. Pain relief, yes, no, woman declines. Oral fluid, yes, no, woman declines. Like that. ठीक है? Similarly, in fetal heart rate decelerations, this is the alert one, late. ठीक है? Amniotic fluid में the thick meconium, 3+ is thick meconium and blood stained are alert वाले. ठीक है? Fetal position में occipito posterior, occipito transverse are alert features. 3+ caput and 3+ molding are alert features. Okay. Now you don't have to remember Asta, but I'm just telling you to make you understand. I don't think you need to know the detail of this, but you should understand कि labor care guide में क्या changes है जो पहले में नहीं थे, इस वाले में है. So this alert column is basically new. The supportive care is new. And what has changed drastically is the labor progress. So there is no alert line, there is no action line, there is no 1 centimeters per hour. That has changed drastically. So what is new in labor progress? So look at the cervical. So descent same है. Descent में कोई change नहीं है. 5/5, 4/5, 3/5 वाला palpable वो same है. But what has changed is the cervical dilatation. So you start plotting at 5 centimeters. Suppose the patient comes and she's 5 centimeters. आपने एक यहाँ पे cross डाला. Now this is the alert column. ये alert वाला column है. When should you be alert? You should be alert if she remains 5 centimeters for 6 or more hours. This means you can allow her to be 5 centimeters for a maximum of 6 hours. अगर आप ये पुराने पार्टोग्राफ पे प्लॉट करोगे तो it would have come as arrest of dilatation. It would have crossed the action line. But यहाँ पे as long as everything else is okay, as long as the fetal heart is okay, there are no decelerations, there is no caput, there is no molding, you can wait. But यहाँ पे 5 centimeters पे you can wait for 6 hours. 6 centimeters पे you can wait for 5 hours. 7 centimeter पे you can wait for 3 hours. 8 centimeter पे you can wait for 2.5 hours. And 9 centimeter पे you can wait for 2 hours. Okay, so these are the upper limits of cervical dilatation. ठीक है, इतना आप वेट कर सकते हो. ठीक है, so this is the cervical dilatation and the alert levels. अगर कुछ learn करना लेबर केयर गाइड में, I would suggest if you can remember these alert values for different cervical dilatation, especially if your aim is the INI-CT exam. तो ये वाला पार्ट जरूर याद करना. 5 centimeters 6 hours, 6 centimeter 5 hours, 7 centimeter 3 hours, 8 centimeter 2.5 hours, and 9 centimeter 2 hours. ठीक है. Another change which is there in the labor care guide is second stage का column अलग से है. पहले वाले में second stage नहीं था. Gautam, it's difficult for me also. I will feel very uncomfortable अगर मैं अभी PV करूँ 5 centimeters और 1 बजे दोबारा my resident does and she's still 5 centimeters. Even if everything else is fine, I will be very anxious, है ना? So it's difficult for everybody to undergo this, but it has been proven by many studies that this brings down the cesarean section rate. Where problem is we're very used to what we have been doing for so many years. Another new thing is the second stage. Second stage was never documented in the old partograph. इसमें एक पूरा अलग column है for second stage. What you have to enter in these boxes is when the patient starts pushing, you have to write P. So if she's pushing, you write P, P, P. Okay? And when she delivered, you write when she has delivered. So this is an example of a filled partograph. So you can see यहाँ पे the patient didn't have a companion here. जो alert वाले हैं, those have been marked in red. So if she didn't have a companion here, बाकी जगह उसका ठीक था. Pain relief, then oral fluid she was taking or she declined. ठीक है, posture, ठीक है, then fetal heart rate, fetal decelerations, then fetal position बीच में occipito posterior transverse हो गया था. So it started with occipito posterior and then it became occipito anterior. ठीक है. Then, so all these things. And then if you see the cervical dilatation, she started with 5 centimeters. Then after 4 hours, she was 8 centimeters. And then after 3 hours, she became fully dilated. So everything was normal. And then she started pushing here. And then यहाँ पे at this point, she gave birth. So this is a more comprehensive labor care record, है ना? And it allows more time for the patient to deliver naturally. ठीक है? And this is the other new column, shared decision making, कि आपने क्या assessment किया patient का जब कोई alert feature आया और उसका क्या plan बनाया. So this is something which is new. So basically, just come to this one. The differences you should know. In the modified partograph, the active phase begins at 4 centimeter. Here the active phase begins at 5 centimeter. This has started coming as a question. Last NEET PG पे भी question था, तो इस पे तो start हो गया question आना. Alert. So here in modified partograph, there was an alert line fixed at 1 centimeters per hour. And action line is 4 hours to the right of the alert line. LCG में क्या है? There are proof-based time restrictions on cervical dilatation at each centimeter. At 5 centimeter, it is 6 hours. At 6 centimeters, it is 5 hours. At 7 centimeters, it is 3 hours. At 8 centimeter, it is 2.5 hours. And at 9 centimeter, it is 2 hours. If you can remember that much, बस उतना ही याद रखो. There is no second stage. यहाँ पे there is a second stage. यहाँ पे there was no documentation of interventions for reassuring help. ठीक है, यहाँ पे देर इज अ लॉट ऑफ एम्फोसिस ऑन कंपेनियनशिप, पेन रिलीफ, फ्लूइड इनटेक, पोस्चर, यहाँ पे ये सब नहीं था। ठीक है, यहाँ पे मेन फोकस वाज द अलर्ट लाइन, एक्शन लाइन। यहाँ पे फोकस इज ऑन एवरीथिंग along with appropriate response and the action taken. या you do nothing, रौनक, कुछ नहीं करना है। ठीक है, you can, if contractions are less you can augment labor, but if contractions are fine you just wait। ठीक है, 5 सेंटीमीटर पे आप 6 घंटे तक आराम से वेट कर सकते हो, कुछ नहीं करना। अगर 6 घंटे के बाद भी डिस्पाइट एवरीथिंग बीइंग फाइन शी इज नॉट डायलेटिंग, देन यू टेक करेक्टिव मेजर्स। या इट्स वेरी डिफिकल्ट टू नॉट डू एनीथिंग। ठीक है, so for whom should the LCG be used? For all women, but high risk women require additional monitoring. Start at 5 centimeters. And where should you use it? At all levels of care, whether you are at the primary healthcare center, whether you're working in AIMS, whether you're working in a top corporate hospital, you're working in a nursing home, everywhere you should use the labor care guide. Okay. Now, which is incorrect regarding the partograph? Alert and action lines are separated by a difference of 4 hours, correct? Each small square represents 1 hour, correct or wrong? Wrong. Each small square represent 30 minutes. Send the patient to the FRU once the progression line crosses the alert line, correct? Because it's the referral line. Partograph recording should be started at a cervical dilation of 4 centimeter. This is also correct because this question was asked a few years back because it's based on the modified partograph. Na alert action line pucha hua hai, so it is based on the modified partograph. A 20-year-old primigravida presents to the labor room at 8 o'clock. She is 41 weeks and has an uneventful antenatal period. On examination, she is 4 centimeter dilated. She is getting 2 contractions in 10 minutes. At 12 noon, a repeat PV is done. She is now 6 centimeters. What should now be done? So now this question you will get confused कि अब हम पुराना पार्टोग्राफ फॉलो कर रहे हैं या नया पार्टोग्राफ कर रहे हैं. So let's discuss both. If you are following the modified partograph, what should you do? She is in the active phase. She is 4 centimeters, but after 4 hours, she should be 8 centimeter. She is only 6 centimeters. और क्या मिल रहा हमें? Contractions are less or okay, they are less. So what do you want to do? You want to augment labor. So you want to do an ARM if you are following the modified partograph. If you are following the labor care guide, what should you do? You should do watchful expectancy. कुछ नहीं करना, ठीक है, everything is fine, we can wait, है ना? Understood? ठीक है, because now she has entered active phase. 4 centimeters पे तो वो active phase में थी भी नहीं. अब हम मान के चलेंगे कि अब 6 cent मतलब 5 centimeters cross हो गया, अब she is in active labor. समझ आया? But this question came from a Purana question, so it was based on the WHO modified partograph. Ideally, the question should specify, as per the WHO modified partograph, what should be done, or as per the labor care guide, what should be done. Okay, they will specify, don't worry. These are from that time of questions before the LCG came. Okay, you should mark as per what is asked. ठीक है, ये उस टाइम का क्वेश्चन LCG नहीं था. ठीक, अब आएगा they will mention. Okay, a 30-year-old primigravida presents at 6 question है. It should be marked. If baby is in distress, Soumya, then you will deliver, है ना? Then you will urgently take action. Those limits are to be followed only if everything else is fine. Lagging. Lag है या ठीक है? Now okay? Okay, it's okay. So you'll mark it on the alert line. ठीक है? A 38-year-old primigravida presents with labor pains and contractions. On examination, she is 2 centimeters dilated and 50% effaced. Her pulse and BP are okay. What should be done next? Very good, Aditya. She is in लेटेंट फेज तो कुछ करना ही नहीं है, लेटेंट फेज में है तो आराम से रहो, कोई जल्दी नहीं है। लेट हर वेट इंक्रीज द कंट्रैक्शंस अपने आप, ठीक है। प्रीवियस क्वेश्चन आई टोल्ड यू ना, द फर्स्ट मार्किंग इज ऑलवेज ऑलवेज ऑन द अलर्ट लाइन, ठीक है। इट इज यू स्टार्ट मार्किंग आफ्टर 4 सेंटीमीटर, बिकॉज वी आर टॉकिंग अबाउट द WHO मॉडिफाइड पार्टोग्राफ, उसी पे अलर्ट लाइन होता है, and the first marking is always on the alert line. Nursing assistant posted in the obstetric care unit was asked to plot a partograph to monitor the progress of labor. After how much dilatation should she start plotting the graph? If you're following the modified, then 4. If you're following the LCG, then 5. Again, they will mention कि कौन सा वाला पूछा गया है, ठीक है। Okay. Now coming to abnormal labor. So we finished normal labor. Now we go to abnormal things. Difference वाला पेज शुभम। अच्छा 1 second शुभम, ये लो। ठीक है। So now in abnormal labor, we are going to talk about occipito-posterior position. Occipito-posterior is an important mal position of the baby where the occiput is facing posteriorly. ठीक है। Now, what should you know about occipito-posterior? The first thing you should know is ये क्यों होता है? What are the risk factors? It is common in anthropoid pelvis. Why is everybody laughing? It is common in anthropoid pelvis, ठीक है। रेयरली, सो एंड्रॉइड में भी होता है, ऐसा नहीं कि एंड्रॉइड में भी नहीं होता है। एंथ्रोपॉइड एंड एंड्रॉइड बोथ, बट एंथ्रोपॉइड इज मोर कॉमन, ठीक है। ऑल्सो इट इज सीन इन ग्रैंड मल्टीपैरा। It is also seen in, why is everybody sending so many emojis? Okay, it is also seen in women in the, if the fetus has a deflexed head. अगर flexion नहीं है, remember deflection very commonly is associated with occipito posterior. Yeah, I'm ignoring the spamming. I think there's a way to switch it off also, na? Okay, deflexed head is seen in occipito posterior. बच्चों पढ़ लो पढ़ लो पढ़ लो, तुम्हारी जिंदगी बन जाएगी। Stop, stop, stop. Okay, study. Okay. Yeah, it's disturbing. I'm seeing how to switch it off. Anybody can help? यहाँ पे ना, कहाँ से? नहीं समझ आ रहा है। क्लिक ऑन रिएक्शन फर्स्ट, कहाँ पे? हाइड रिएक्शन इन मोर, 1 second। मोर, हाइड रिएक्शन नहीं आ रहा। हाइड फ्लोटिंग मीटिंग कंट्रोल्स। I'm trying to ignore, yeah, but then it's just distracting for everybody. It's very bad. Very, very bad. I'm very disappointed. Okay, let's continue. So, deflexed head, anthropoid, and android pelvis, grand multiparas. These are where you see it more commonly. Ignore karo. 1 second. Okay, I found how to control it. ठीक है. Okay. I've done it. I've hidden the reactions. Okay, come. Let's continue. So anthropoid, android pelvis, but anthropoid is more common. Grand multipara, deflexed head, cephalopelvic disproportion. In these patients, occipito-posterior is more common. The next question that can come and that came in last year's NEET PG was, how will this patient present? So what are the clinical features? Now, what are the symptoms? The symptoms the patient can present with is PROM. She can, during labor, she can present with premature bearing down. Why? Because the occiput is posterior, तो वो rectum पे pressure देता है. So she can have a feeling of premature bearing down. Okay, it also presents with incomplete urinary evacuation. So she keeps wanting to go to the washroom again and again. These are common symptoms. And when you examine this patient, so normally on inspection in a pregnant woman, the abdomen is nicely rounded, है ना? But occipito-posterior, because the baby's back is like this, occipito-anterior में the contour of the abdomen is like this. Premature bearing down means bearing down कब होता है? Second stage of labor में होता है. If the patient starts pushing in the first stage before full dilatation, it is called as premature bearing down. ठीक है? Occipito-posterior में क्या होता है? This is how the abdomen will look like. Because the back is posterior. यहाँ पे limbs होते हैं बेबी के, है ना, legs and feet. So this will appear as a sub-umbilical flattening. This is the buzzword. It is the typical feature on inspection in an obstetric examination. Sub-umbilical flattening. That roundness of the abdomen goes off. Okay, so sub-umbilical flattening, PROM, premature bearing down, incomplete urinary evacuation. These are common symptoms of occipito-posterior position. Now, what's the next question that comes? Next question comes is occipito-posterior position में what happens during labor? Yes, very good. Heartbeat in flanks, pediatrician. Thank you. I forgot that. And on examination, one more thing is the fetal heart rate is best heard through the flanks, because usually क्या होता है, the fetal heart rate is best auscultated through the baby's back. अब back पीछे की तरफ हो गया है, so it's best auscultated through the flanks, not through the front of the abdomen, through the flanks. ठीक है? Yes, and an unengaged head at term because it is deflexed. Thank you for adding the missing points. So delayed engagement of the head. ठीक है? And also, what else? The fetal heart rate heard at the flanks. These are the examination findings. Now, what happens during labor? Now, look at this picture. This is an occipito-posterior. Just forget this. ये right left मत सोचो, because ये diagram गलत है. ठीक है? ये डायग्राम को जितना ज्यादा देखोगे ना, समझने की कोशिश करोगे कि ये राइट ऑक्सीपिटो पोस्टीरियर है या लेफ्ट है, आप उतने कंफ्यूज हो जाओगे. जस्ट फॉरगेट द पेल्विस, just look at the fetus, ठीक है? And just imagine this is posterior, this is anterior. This is an occipito posterior position. Why is it an occipito posterior? Because this is the occiput, ठीक है, the posterior fontanelle, and वो posterior की तरफ है. ये मत सोचो कि right है या left है, because ये diagram ही जहां से मैंने लिया था वो एक्चुअली वो गलत है. ठीक है? सो दिस इज अ ऑक्सीपिटो पोस्टीरियर पोजिशन. नाउ व्हाट कैन हैपन इन दिस सिनेरियो, इन द mechanism of labor, what can happen? Now, if you go back to the cardinal steps in mechanism of labor, you have engagement. What all do we have? Let's write on. We have engagement, we have descent, we have flexion, internal rotation, extension, restitution, and external rotation. And these are the cardinal steps. So what's happening in occipito-posterior? In majority of occipito-posterior, what's going to happen? This is going to happen. That means engagement हो गया, descent हो गया, flexion हो गया, और flexion हो जाए तो internal rotation will happen by 135 degrees. That is called as long arc rotation. So this occiput travels all the way to the anterior part and becomes occipito-anterior. And then the same steps: extension, restitution, external rotation. ठीक है. So in 90% of patients with occipito-posterior, things are going to be normal because the occiput will rotate by 135 degrees. ठीक है, whether it is, if it's ROP, it will become occipito-anterior. If it's LOP, it will become occipito-anterior. Right or left doesn't matter. Ignore right or left. Whether it is ROP or LOP, it will rotate by 135 degrees and become occipito-anterior, and things will be fine. In a minority of patients, in around 10% of patients, what's going to happen is that instead of long arc rotation, short arc rotation is going to happen. Why short arc rotation? See, it's going to happen from here. This occiput goes यहाँ पे. ठीक है, so the occiput goes पीछे की तरफ and the head comes out like this. Now, when this head comes out, this is what is going to happen. So just 1 second, I'll show you. So you have, this is the pelvis. Okay, this, what I'm showing you here is left occipito-posterior. Okay, so this is my left side and left occipito-posterior. Okay, so either this can go all the way like this, okay, or it just goes 45 degrees पीछे. Now, अगर 45 degrees पीछे हो जाएगा, so the baby is going to come out like this. Okay. Now, when the baby comes out like this, can you see the face is facing the pubic symphysis? This is called as a face to pubis delivery. So, face to pubis happens when it is a direct occipito-posterior. When the occiput is posterior and the baby's head is born, the baby head will be born like this. As against normally क्या होता है? Normally occiput ऐसे होता है और baby ऐसे निकलता है ना? But इसमें क्या हो रहा है? बेबी ऐसे है तो बेबी ऐसे निकल रहा है. द फेस इज फेसिंग द pubic symphysis. Okay, so what is happening here? In 10% of patients, this baby is born by face to pubis delivery. ठीक है? Okay, so face to pubis, and the problem with face to pubis is although things are okay, but this is associated with a higher perineal tears. So it's a good idea to give an episiotomy, okay, because a wider diameter is distending the perineum. Okay, so this is what's happening. In a very small minority, in less than 1%, what happens? The journey starts for long arc rotation. तो 135 degrees पे start हुआ, ठीक है, ऐसे जाता रहा, but जब ये transverse diameter पे पहुंच गया, it gets stuck. Okay, and this commonly happens when the pelvis is an android pelvis. At the level of the ischial spine, the sagittal suture gets stuck in the transverse diameter of the pelvis, and despite good uterine contractions, and this is called as deep transverse arrest. Okay, this is not face presentation, Gaushalya. This is face to pubis delivery. Face presentation अलग है. ठीक है, ये है face to pubis. It's an occiput, but the face is facing the pubis. Okay, is it okay or is there a lag? मुझे ऐसा लगा lag हुआ है. It's okay, ठीक है. So this is deep transverse arrest. So majority, what's going to happen? Everything is going to be fine except that internal rotation will be 135 degrees, long arc rotation. In 10%, short arc rotation, face to pubis delivery, and this commonly happens in an anthropoid pelvis. This came in this year's NEET PG question. Face to pubis is most commonly seen in anthropoid pelvis. ठीक है? DTA is common in android pelvis. ठीक है? And what else you should know is one more thing can happen. That is, nothing happens. It remains like this. No rotation happens at all. This is called as persistent occipito-posterior. Okay, and if it's persistent OP, you will do a cesarean section. In a deep transverse arrest, you have a choice. Okay, so DTA you can deliver either by a vacuum delivery, or by a cesarean section. So if the patient is a primigravida, then the cause of DTA is likely to be a android pelvis. So cesarean section is the treatment of choice. Primigravida or a multigravida with features of obstruction. So obstructed labor agar hai, whether it's a primi or a multi, if there are features of obstruction, treatment is cesarean section. But sometimes DTA happens in a multigravida, especially grand multigravida, जहाँ पे pelvis में problem नहीं है. फिर why is it getting stuck? Because of lack of resistance from the pelvic floor. The pelvic floor is very lax. So internal rotation पूरा complete नहीं हो पाता है. In such a case, when there is no signs of obstructed labor, in such patients, you can deliver them by doing a vacuum delivery. Okay. Okay, vacuum or ventouse. There is no role for forceps here because here you will use rotational forceps and the head is at zero station. It's very high for forceps. So vacuum delivery is the best if there are no signs of obstruction. But when there is obstructed labor, whether it is a primi or a multi, you will do a cesarean section in deep transverse arrest. So what is DTA? It is arrest of the head at the level of the spines with the sagittal suture in the transverse diameter of the pelvis despite full dilatation, despite good uterine contractions. Again, I will say if it is a primary or a multi with obstructed labor, what will you do? You will do a cesarean section because it's a the problem is in the pelvis. But if it's usually a grand multi will also present like this with no obstruction, then you can use a vacuum and take the baby out. Okay. DTA, no. DTA is a sign of obstruction only if the pelvis is abnormal, if it's an android pelvis. But DTA can happen in a grand multi also. What's happening here is rotation पूरा नहीं हो पा रहा है. क्यों? क्योंकि elevator ani is very lax. So the rotation is not happening. Okay, what is a grand multi? Somebody who's had more than 5 normal deliveries. Okay. Signs of obstruction 3 plus caput, 3 plus molding, patient is dehydrated, head is jammed in the pelvis. Those are signs of obstruction. Okay. Now coming to breech presentation. Again, a very, very important topic. Commonly asked question. Okay. Can't see the chat box. Pavan, I don't know. Everybody else can see. I don't know why you can't see the chat box. Concentrate here. Even if you can't see the chat box, koi baat nahi. ठीक है. Now coming to etiology, what are the causes of breech presentation? What is the most common cause of breech presentation? The most common cause is you can't see what? You can't see the chat box. It's okay. I'm not writing on the chat box now. I am speaking to you. You can anyway, you can see your doubts when you're writing. लीव करके दोबारा ज्वाइन करो, मे बी यू विल सी इट देन. ठीक है, और मे बी यू आर द वन स्पैमिंग मी एंड हेंस यू आर ब्लॉक्ड. आई डोंट नो. ओके. मोस्ट कॉमन कॉज of breech is preterm baby. So prematurity is prematurity is the most common cause. At 28 weeks of pregnancy, 25% of fetuses will be in breech. At term, this comes down to 3%. So the incidence of breech at term is 3%. The incidence of breech at 28 weeks is 25%. So as the gestational age increases, the baby is going to turn and the head, because it is heavier because of gravity, goes down. Okay, what are the other causes of breech? What are the other causes of breech? It could be oligohydramnios, polyhydramnios. In oligohydramnios, there is no space for the baby to move. तो अगर वो breech है, वो breech ही रहेगा. पॉली में बहुत ज्यादा जगह है घूमने का, तो बच्चा घूमता रहता है. देन इफ देयर इज एन एनोमली, अ फीटल एनोमली, or even a Mullerian anomaly, placenta previa. What else? If there is multiple pregnancy, twins, triplets, breach is common. What else? If there's a short umbilical cord, the baby can't move too much, so it tends to remain in breech presentation. So these are the, you can say breech at any gestational age बच्चा. Even 28 weeks जब आप Leopold maneuver करोगे तो breech कहोगे ना, अगर breech है तो breech कहोगे. ठीक है. Fibroid, a large tumor not allowing the baby to move, fibroid uterus. So these are the common causes of breech presentation. And what you need to understand, number one, is diagnosis. How will you diagnose on clinical examination? If you do the Leopold maneuver on the fundal grip, what will you find? You will find the head. That is a hard, ballotable structure. And on the lateral grip, what will you find? One side will be the back, one side will be the limbs. है ना? If you do the third maneuver, this is the pelvic grip, first pelvic grip or the Pollock maneuver. What will you find here? You will find a firm, broad, non-ballotable structure. And second pelvic grip करने पे क्या होगा? Second pelvic grip पे your depending on whether the breech has gone inside or not gone inside, your hands will approximate or not approximate. ठीक है? Yes, Jagdish, there are only two pelvic grips. कल का क्लास में हमने किया था, है ना? So you have the fundal grip, the lateral grip, the first pelvic grip, and the second pelvic grip. The first pelvic grip is also called the Pollock's grip. So your first, of course, you will diagnose this on an examination and you will confirm this by doing an ultrasound. So an ultrasound, you will see the presentation, and ultrasound will also be helpful because it will help you understand if there is a possible cause. So you can see the amniotic fluid index. Is there oligopoly? Are there twins or triplets? Is there placenta previa? Okay, is there any anomaly? So an ultrasound helps determine a possible cause also for the breech presentation. It will confirm your diagnosis and tell you if there's a possible cause. Now, what are the types of breech? Types of breech, look at the first one. This diagram is wrong. ठीक है, please change this. I'll tell you अभी first tell me the first one. ठीक है, ये दोनों same आ गए, ये same नहीं है, different है. The first one is flexion at the hip joint and extension at the knee joint. So flexion at hip and extension at knee. So what is this? This is a frank breech, also called an extended breech. Okay, frank or extended breech. What is the second one? Just in the second one, please make the knees flexed. Okay, ऐसा नहीं है इसका. ठीक है, the knee is flexed. So you have flexion at the hip and the knee. What is this? This is a flexed breech or a complete breech. Complete or a flexed breech. Then you have the third one where you have extension at the hip and extension at the knee. This is a footling. The foot is the presenting part. So these are basically different attitudes of breech. Like we had flexion, extension in the head. These are different attitudes of the breech depending on flexion or extension. Here you have extension at the hip and flexion at the knee. So this is a kneeling. The knee is the presenting part. Okay. Meteor anencephaly can lead to both. Anencephaly can lead to polyhydramnios. Polyhydramnios can lead to preterm labor. Also, anencephaly में brain नहीं है. ठीक है, so brain नहीं है, so what happens? One of the hypotheses of onset of labor is the fetus releases cortisol releasing hormone, CRH. तो बेबी का ब्रेन नहीं है तो CRS रिलीज नहीं होगा, तो ऑनसेट ऑफ लेबर डिलेड होगा. सो it can even lead to post-term pregnancy. So anencephaly can lead to both preterm because of polyhydramnios and over distension of the uterus, and it can lead to post-term also. दोनों चीजें हो सकते हैं. ठीक है. Now this is the types of breach. ठीक है. Now coming to management, if you have a patient with breach presentation, सबसे पहले क्या कर सकते हो? So the first thing the patient asks me also in the OPD, any patient will ask कि breach है, आप patient बोलेगा मैम ये turn नहीं हो सकता क्या, इसको turn कर सकते हैं क्या? That's the first thing that should come in your mind when you have a question in the exam. In clinical practice, we don't do it so commonly. In the West, they do it very commonly. In medical college, some medical colleges, they do it very routinely. But it's not something in India which has picked up too much. But in the exam, it's very important for you to know that if, yes, it's an option, you should opt for it. Okay? External cephalic version, ECV. Okay, so ECV is something which should be offered to patients who have breech presentation. The best time to do so what is external cephalic version? Externally, you're moving the baby from breech into cephalic. The best time is between 36 to 37 weeks. उससे पहले करोगे तो बच्चा रिवर्ट होने का चांस ज्यादा है. It will turn back to breech. ठीक है. And also, if an emergency arises, then you might have to take out a preterm baby. If abruption happens or leaking happens, then you end up taking, or distress happens, it ends up in a preterm baby. And after 37 weeks, the baby becomes bigger. The amniotic fluid goes down. So it becomes more difficult to do. Okay. So 36 to 37 weeks is the best time. What is the success rate? The success rate is almost 60%. So this should be offered to all women. If there are no contraindications, you should offer it to all women who have a breech presentation. What are the contraindications when you can't? So what is your aim of doing an ECV? Your aim of doing this is to achieve a vaginal delivery. अगर vaginal delivery वैसे possible नहीं है तो इसको करने का कोई फायदा ही नहीं है. If you can't achieve a vaginal delivery, if you're anyway going to do a cesarean section, then there's no point doing this and putting the patient and the baby mainly at risk, right? So what are the absolute contraindications to an ECV? Placenta previa. Okay, you're anyway going to do a cesarean. Similarly, a small pelvis, contracted pelvis, although this is a bit I just told you, you can't do a clinical estimation of a pelvis, but agar बहुत ही grossly contracted pelvis hai, you should not do it. Twin pregnancies. Twin pregnancy mein when both the babies are inside, there is no role of ECV. Only when one baby is out and the other baby is transverse lie. Remember, first class, उसको हम turn कर सकते हैं. ठीक है, second class. Hyper extended head or star gazing fetus. When the baby's head is like this and ये ultrasound पे दिखता है, then this it's not going to turn, and even if you turn and the head remains like this, it's going to be very difficult to do a vaginal delivery. If there is a uterine anomaly or even a fetal anomaly, then there's no point doing an ECV. If the baby is dead, doesn't matter ना, उसको वैसे ही deliver करा लो breach होते होते. If the baby is distressed or if the patient has denied consent, then these are absolute contraindications to doing an ECV. Remember, a previous cesarean section is not an absolute contraindication. You can do an ECV. Many studies, many studies are there, and Williams also says you can safely do an external cephalic version. हमारा main डर क्या है कि rupture ना हो जाए, scar rupture ना हो जाए, है ना? But it can be done. It has been reported to be safe. So previous cesarean section is not an absolute contraindication to doing an external cephalic version, and this has come as a question. Okay. Now, what are the favoring us, the factors favoring a successful ECV? Which patients do you think ECV will be more successful? If she's a multiparous, you have a higher likelihood of getting a better result. If the breech hasn't entered the pelvis, If the amniotic fluid is good, if it's need, it shouldn't be too less, it shouldn't be too more. Oligo, poly are not contraindications to doing a ECV. The success will go down, okay, but you can do it. If the amniotic fluid is normal, the success is better. And if the placenta is posterior, it is easier to do. Placenta anterior है तो आपको you will not be able to grip the baby properly to do an ECV. Okay, so these are the factors favoring a successful external cephalic version. Now, so your first option is to do an ECV. So if the ECV is successful, then your problem is solved. You either induce the patient or you wait for spontaneous onset of labor, but you will try for a vaginal delivery. But if the ECV is unsuccessful, or the patient doesn't consent, or there is some contraindication, doesn't consent is the most common reason. Okay, yeah, we don't do it many of the times. So then what do? Then so it remains breech. So basically it remains breech. Now, how will you deliver a breech? Now you have two options. Okay, you don't give general anesthesia and ECV, bache, you do it. You can give tocolysis, but that is also not compulsory. Okay, it is done as an OPD procedure. Now, if it remains breech, अब हमारे पास दो ऑप्शन है, या तो हम सिजेरियन कर दें या हम वेजाइनल डिलीवरी के लिए ऑप्ट करें. What is the main worry in doing a vaginal delivery for breech? Why are we so scared? Yes, the head can get stuck. The aftercoming head of the breech, if it gets stuck, remember, once the body is out, you have 5 minutes to deliver the head. उससे ज़्यादा time लगा तो the baby becomes hypoxic. So there is an increased incidence of birth trauma and hypoxia and fetal death in assisted breech delivery. So you have to carefully decide कि किस पेशेंट में आप अलाउ करोगे, किस पेशेंट में आप अलाउ नहीं करोगे. So what are the factors against an assisted breech delivery? In which patients will you not allow an assisted breech delivery? Primary breech. If she's a primary breech, I will tell her कि आपका pelvis tested नहीं है, कोई भरोसा नहीं है, कब अटक सकता है head. Let's be safe. Let's do a cesarean section. Preterm breech. So preterm में क्या होता है? The head is bigger than the body. The body slips through, but the head gets stuck. Again, don't do a vaginal delivery. Big baby, stargazing fetus, complicated breech. What do you mean by complicated breech? Complicated breech means breech plus any other medical complication like preeclampsia, or breech plus GDM, or breech plus oligohydramnios. So any breech with any other complication is called a complicated breech. It's better to do a cesarean section. एक complication तो है ही, उसके ऊपर एक breech भी हो गया. Why take a risk? If she's previous cesarean, don't do us. You can do ECV, but you should not do an assisted breech delivery. Okay. Lack of skilled personnel. मैं क्लास ले रही हूँ, एक पेशेंट ब्रीच करके आ रही है हॉस्पिटल में. माय रेजिडेंट इज कॉलिंग मी एंड सेज कि मैम एक ब्रीच आ रही है, व्हाट शुड आई, एक ब्रीच आई है लेबर में, मैं ले लूँ डिलीवरी? तो आई आस्क, आपने कभी ब्रीच डिलीवरी ली है? स्टक, एम आई स्टक? तो शी विल से कि नहीं, कभी नहीं ली है. So I will say no, you've done cesareans, please do a cesarean, है ना? So I can't come right now, you do a cesarean for her. So lack of skilled personnel, ठीक है? Footling or kneeling because of the higher incidence of cord prolapse. ठीक है? So these are where you will want to do a cesarean section. You will prefer to do a cesarean section. Primary breech, complicated breech, preterm breech, big baby, don't know how to do a breech delivery, previous cesarean, and whether it is footling or kneeling. Okay. Now, what are the types of breech delivery? So suppose ये सब नहीं है, everything looks fine, you want to do an assisted breech delivery. Okay? So what are the types of breech delivery? One is a spontaneous breech delivery, one is an assisted breech delivery, and one is a total breech extraction. क्या डिफरेंस है तीनों का, क्या मतलब है? स्पॉन्टेनियस ब्रीच डिलीवरी मींस आप बिल्कुल भी हेल्प नहीं कर रहे हो, पेशेंट हैज कम एंड शी डिलीवर्स, शी एक्सपेल्स द ब्रीच इन वन पुश, शी एक्सपेल्स. दिस यूजुअली हैपेंस व्हेन शी इज वेरी प्रीटर्म, like 28 weeks, 24 weeks, very preterm breach. कुछ करने की जरूरत नहीं, everything comes out, you don't need to assist anything at all, it's a small baby, it will come out. What is assisted breech delivery? जो जिसमें सारे वो maneuvers हैं, where the baby requires assistance for delivery. Okay, that is assisted breech delivery. And what is total breech extraction? जो हमने पढ़ा in twin pregnancy, internal podalic version, breech extraction. Everything you are doing, अंदर हाथ डाल रहे हो, पैर खींच रहे हो और बाहर निकाल रहे हो बच्चे को. So everything you are doing. So he assisted breech means you're giving assistance, but some of it comes out by itself. Total breech extraction means you are completely, the obstetrician is delivering the baby from putting your hand inside to taking the baby out. This is usually done under general anesthesia. Okay, and it's usually done along with internal podalic version in a second of twin in transverse lie. So I hope you remember the class on twin pregnancy. Second of twin, if it is transverse lie, you first try to do an external version. If that fails, you take the patient to the OT under general anesthesia, put your hand inside, do an internal podalic version and total breech extraction. Okay? Now, correct. In assisted breech delivery, what is done is that the breech is allowed to deliver till the level of the umbilicus. Uske baad you start helping the baby. Till that time, you don't need additional help. The baby will come out by itself. You just encourage the mother to bear down, give an episiotomy, and when the umbilicus is seen, that is when you start to assist. What are the important maneuvers that you should know in an assisted breech delivery? One is the Lofset maneuver. What is this maneuver? This came as a question, I think, recently. Lofset maneuver is when the arms are like this. तो कभी कभी arms निकलते नहीं है. And when you're doing the breech delivery, you're supposed to hook out the arms of the baby. So this is the baby. Okay, so the baby is born till here, and you just put your hand on the side and the arms come out. But if the arms are overhead like this, so simply hook the arms don't come out just by hooking out. What do you have to do? You have to do Lofset's maneuver, where you turn the baby by 180 degrees, then you turn the baby, you turn the baby by make it in the anterior posterior plane, and then rotate it by 180 degrees. So this will dislodge the arms. This is called as Lofset's maneuvers. Just remember this image and just remember it is done to dislodge the arms of the baby if you are unable to hook them out otherwise. Okay, so Lofset maneuver. Pinard maneuver. Bhavesh, so Pinard maneuver is asking what is Pinard maneuver? Pinard maneuver, no? Sorry, Pinard maneuver is a maneuver we do in total breech extraction. It is not a maneuver we do in assisted breech delivery. Assisted breech delivery may we let the baby's legs come out by themselves. Okay? We might have to hook out the legs. But Pinard mein kya hota hai? We put our hand inside and we pinch the popliteal fossa. Once you pinch the popliteal fossa, the baby will extend its leg and you can grab the foot. So it is basically pinching the popliteal fossa. So the baby extends its leg and then you grab the foot and then you खींचोफy the baby outside. ठीक है? Pinard is not a maneuver for assisted breech delivery. It is a maneuver we use to grab the foot of the baby when we're trying to do a total breech extraction. Okay, so it's pinching the popliteal fossa so we can grab the foot. Nice, Jigar. So you've done so we have somebody who's done a breech delivery here. I'm very glad you've had that experience, so you understand this better. Okay, so he had a twin delivery where one was the first you did an assisted breech delivery, and the second was what? The second was one was cephalic. So you gave two episiotomies. Okay. Tired today. I know it's a lot today, but let's see how much more we can do, and then we'll see. If required, we will take some more extra hours. Let's see. Okay, don't worry. Then these two are very important. The most important in a breech is the head getting stuck. You are kicked out of the labor room in a triplet vaginal delivery. Why were you kicked out? कोई वीडियो बना रहा होगा इसलिए नहीं. Okay, anyway, after coming head में क्या होता है? Your this is the step you're most worried about. The head can get stuck. When the head gets stuck, Prashant, Pinard is included in breech delivery. It is just not a part of assisted breech delivery. Okay. So when the head gets stuck, you can either, very commonly this maneuver is done. This came in this year's NEET PG as an image-based question. This is the Byrne-Marshall maneuver. Okay, the Byrne-Marshall maneuver. Okay, so you can do this maneuver where nothing much is done. Basically, you hold the baby by the feet, okay, and you just pull the baby over the maternal abdomen. But this maneuver can cause injuries at the atlanto-occipital joint. So you have to be very careful. And you can see one person is giving suprapubic pressure. This is maintaining flexion of the fetal head. So this is Byrne-Marshall technique. Then we have this one. This is Morisot-Smalley-Viet technique. What is done here? Here you can see again suprapubic pressure is being done, but here the baby is put on the hand, on the arm of the person of the obstetrician, and this hand is causing traction, malar traction, and this hand is pushing the occiput in front. So basically this is causing flexion. So flexion is very important even in breech delivery. A flexed head comes out easily. So this is called the Morisot-Smalley-Viet. Morisot-Smalley-Viet maneuver. Okay. So Byrne-Marshall is nothing much. Byrne-Marshall is just putting your fingers like this. Okay. And just sweeping the baby over the maternal abdomen. तो वो बच्चा अपने आप ही आ जाता है बाहर. ठीक है, many times. Now, one important thing in breech you should see is the back has to always be kept anterior. Look here, the back is anterior. Look here, the back is anterior. So that's one important step you should note in breech delivery. The back should be kept anterior. मुंह में हाथ नहीं डालते, malar eminence, cheeks पे two fingers डालते हैं जिससे खींचते, you pull it towards the neck. So you cause flexion by doing malar traction and pushing the occiput like this. So you're causing flexion with this finger and you're causing flexion with these two fingers. Okay, so Morisot-Smalley-Viet is done by this and the baby comes out like this. Okay. A good way to deliver the baby is by using Piper forceps. Piper forceps में क्या होता है कि the pulling on the fetus is avoided. So this is associated with less trauma, less birth injuries, less atlanto-occipital injuries because it's a very controlled delivery. So Piper forceps comes as a question. It is a good way to deliver the breech, the head with very less trauma because it is a controlled delivery of the aftercoming head. पाइपर देखो, देयर आर टू फोरसेप्स जो एग्जाम में आता है. एक होता है रिगलीज, एक होता है पाइपर. पाइपर का जो हैंडल है ना, इट इज लॉन्ग, so it has a long handle. Wrigley ka handle is short. When I show you the Wrigley forceps, you'll understand. Piper has a long handle, Wrigley has a short handle. Okay. So that is, this has a short handle. This has a long handle. So that ends breech delivery. Let's take a 5-minute break. Okay. Let me see what all is left and then we decide how much more to do today. Okay. So 5-minute break. Okay. Then we'll come back. आज बस अच्छा देखने दो है ना, बिकॉज अगर आज बस करेंगे तो मुझे एक और दिन एक्स्ट्रा मांगना होगा फॉर कंप्लीटिंग द सिलेबस, है ना. Let us finish shoulder dystocia, transverse lie, and cord prolapse. These are small topics. ठीक है. PPH and others will remain. Those are very important topics. And then I'll have to ask for an extra class, maybe not a full class, but at least 2 hours more. So maybe on the day of the END, we can take some more time or a separate day completely. ठीक है. And then we see tomorrow. Possible नहीं है. Tomorrow is very close to Diwali and I am busy, है ना. But I need to ask, what are your free days after gynae directly pediatric? क्या start हो रहा है? Pathology start हो रहा है. Okay. But I'm sure you'll be having some free days in between. Second को possible नहीं है मेरे लिए. I'm busy. Third, fourth, fifth को तो class है ही, तो that will anyway doing. END वाला दिन तो we'll have a lot of time to cover. But let me speak to the team. कोई बात नहीं. आज एक काम करते हैं, आज 5 minutes बाद मिलते हैं. Let's finish these important topics. ठीक है. Shoulder dystocia छोटा topic है. Cord prolapse, transverse lie बहुत छोटे topics है. It will just take 30 minutes more. Okay. And then we will complete, find a day and complete it. ठीक है. 11th is a free day. Okay. Then maybe I can take 2 hours on 11th, है ना. And finish the little small वाले topics आज complete कर लेते हैं. ठीक है. Okay. 1 second. Okay. So now we go to a very important topic. It's a very small topic, but it's a very important topic, that is shoulder dystocia. Now, shoulder dystocia, what is shoulder dystocia? It is when the head comes out, but the shoulders get stuck. You can't deliver the shoulders. So it's a very scary situation. It's an obstetric emergency. And I told you in the beginning, obstetric emergencies are very commonly asked in the exam. Now, the exact definition of shoulder dystocia is, if you want an objective definition, it is when 1 minute elapses between delivery of the head and the shoulders, and you are unable to deliver the shoulders. Okay, or the delivery interval between head and shoulders is more than 1 minute. Okay. The other more practical definition is when maneuvers are required to deliver the shoulders. Normally shoulder nahi aa raha hai. Normally kya hota hai, when the head comes out, we wait for restitution, external rotation, and then we give gentle traction. The anterior shoulder comes out, and then the posterior shoulder. But if you require maneuvers are required to deliver the shoulder, then it is called as shoulder dystocia. Okay. So this is shoulder dystocia. Okay. Yeah, even I read that news, Jagdish. Okay, now coming to what are the risk factors and what do you see clinically? So clinically it's diagnosed by turtle sign. Clinically, the obviously diagnosed ho jayega ki you are unable to take out the shoulders, but this is typically called the turtle sign. So you have a turtle who recedes its head back inside the shell. Okay. So similarly, if the shoulders don't come out, what happens? The head tends to go back inside the vagina. Okay. So that is called the turtle sign. Now this is nothing important, Dr. Asta, nothing important. I can also take till 1 o'clock. Okay, I'll also take till 1 o'clock. Let's see how much we're able to cover. Don't worry. Now coming to uh, the risk factors. Which patients do you find? But I don't want to take a class with things going above the head just to complete the course also. So let's see how people are finding it and then we'll decide. Now, risk factors for shoulder dystocia are: number one, a big baby, है ना, macrosomia, especially in the setting of gestational diabetes mellitus, because in GDM, the the fat is laden more on the shoulders of the baby than anywhere else. A previous history of shoulder dystocia increases the risk of shoulder dystocia. Okay, if you have used forceps or vacuum, say if you've taken the head out, many times these patients will have shoulder dystocia, the shoulders get stuck. So these are some risk factors for having shoulder dystocia. Now it's a very scary thing to happen. So there is a mnemonic to remember the shoulder dystocia drill. What should you do? Everybody in the labor room should know the shoulder dystocia drill. The mnemonic is the helper mnemonic. So let's understand the helper mnemonic. H is help. Okay. Second is give an episiotomy. Okay. And the episiotomy is not to prevent tears. The episiotomy is to allow room for you to do the maneuvers which may be required. Giving an episiotomy creates a lot of space. You can put your hand inside the vagina. Okay. So call for help, give an episiotomy, but the most important maneuver which will relieve up to 90% of shoulder dystocias is the Mac-Roberts maneuver. What is the Mac-Roberts maneuver? It is this maneuver. It is hyperflexion and abduction of the hips on the maternal abdomen. So the assistant or the nurse or your assistant, whoever's there, should immediately, when this happens, hyperflexion of the thighs on the abdomen, hyperflexion and abduction will correct the shoulder dystocia. How does it do it? By pushing the sacrum behind. This maneuver pushes the sacrum behind and displaces the pubic symphysis आगे की तरफ, and that this impacts the shoulder. Okay, so this is the Mac-Roberts maneuver. So first line maneuvers are help, episiotomy, okay? Just cut this out. Mac-Roberts maneuver, of course, you will not give a fundal pressure, but that's not part of the mnemonic, okay? Avoid fundal is part of the process, but it's not a step in the mnemonic. And last, P is suprapubic pressure. Okay, so HE legs, this is legs, HELP. P is suprapubic pressure. So you can see here suprapubic pressure is being given. This dislodges the shoulder from underneath the pubic symphysis. So again, the first line maneuvers are help, episiotomy, okay, legs, that is Mac-Roberts, and suprapubic pressure. So majority of the times this will relieve the shoulder dystocia. These are the first line maneuvers. But if this fails, then you have to move on to the second line maneuvers. In the second line maneuvers, just cut this out again. Okay, what was the mnemonic? HELP. These are the first lines. Then ERR. So just write down this ERR. What is ERR? E stands for enter the rotational maneuvers. What are the rotational maneuvers? I will just come to that. What is this R? This is remove the posterior arm. Okay. And what is this R? This is roll on all fours. That is make the patient go on the all four position, also called the Gaskin maneuver. Okay. These are the second line maneuvers. Repeat, second line maneuvers are the rotational maneuvers. R is for remove the posterior arm and R is for roll on all fours. What are the rotational maneuvers? Now, the rotational maneuvers are two. One is the Rubens maneuver and the second is the wood corkscrew maneuver. Now, what are these maneuvers? Rubin maneuver ye wala hai. You put your hand inside and try to adduct the shoulder. That means bring the arm close to the chest. Ya to anterior wala try kar lo ya posterior wala try karo. You can do any of them. Bring the anterior arm close to the chest if your hand is able to enter from here. If your hand can access the posterior arm easily, try to adduct the posterior arm. So basically, trying to adduct the arm, either the anterior or the posterior, whichever your hand can get access to. What does this do? This will reduce the biacromial diameter and the shoulder can come out. Now, if the Rubens maneuver fails, then you move on to the wood corkscrew maneuver. What is the wood corkscrew? कि इसी को continue करो. मतलब adduct your at the shoulder, but it hasn't got disimpacted. So rotate this whole baby by 180 degrees. Your hand is here. Try to rotate this baby by 180 degrees. Once you are rotating, in that process of rotation, the arm comes out. So that's the wood corkscrew maneuver. इस picture में posteriorly से दिखाया हुआ है, but you can do it from anteriorly also. So you can do it either like this from the anterior, go and move it 180 degrees, or you go from posterior shoulder and try to rotate the baby by 180 degrees. Both are fine, hai na? So if Rubens fails, what do? You continue moving the baby by 180 degrees. And that is called the Wood's corkscrew maneuver. And many times this will release the stuck shoulder. Okay, so these are the rotational maneuvers. Rubens maneuver, wood corkscrew maneuver, and if this fails, then you go to the remove the posterior arm. What does this maneuver say? This maneuver says कि put your hand posteriorly, ठीक है, pinch the cubital fossa and the baby will flex its arm, and sometimes you can grab the hand and pull the hand out. Okay, so remove the posterior arm means putting your hand posteriorly trying to find the hand of the baby and pulling the hand outside. Okay, it's not as easy as it sounds. It's very difficult because space ही नहीं होता है. But this can be tried. Removing the posterior arm is the R. So E क्या था? Enter rotational maneuvers. उसमें Rubens and Woodcock screw. Second is remove the posterior arm. Third is roll on all fours. That is the Gaskin's maneuver. Nothing under GA. आपके पास time ही नहीं है आशुतोष. This is happening in the labor room. In seconds to minutes, you have to do this. In fact, the guidelines say कि every maneuver you should not spend more than 15 to 20 seconds on. Okay, because the longer you wait, this baby is going to get hypoxic and can die. ठीक है. Gaskins क्या है? Ask the mother to roll over on all fours. This rolling over creates more space. Okay, so roll over करके you try all the maneuvers again, but in this position. This many times allows more space and you can deliver the baby. I have never had to reach this far, honestly. ठीक है. And if this also fails, then you go to the third line maneuvers. Third line maneuvers may we have the Zavanelli. Zavanelli is just putting the baby. तो restitution से वापस आप उसको turn कर दो baby को, वापस head अंदर डाल दो, ठीक है? And do a cesarean section and take the baby out. So push the baby head inside and do a cesarean section. You can also do a cleidotomy, which is a fracture of the baby's clavicle. Okay, with scissors, you can take and fracture the baby's clavicle, or you can cut the pubic symphysis with a scalpel, of course, after giving local anesthesia, and this will dislodge the anterior shoulder. Okay, these are again last resort maneuvers. So just to quickly recapitulate, because it's important, you have the helper mnemonic. Okay, helper mein these are the first line: call for help, episiotomy, legs means Mac Roberts में क्या कर रहे हो? Hyperflexion and abduction. This is the most important. This everyone should know. If you forget everything else, ये वाला आपको नहीं भूलना है because ये सबसे important है. Then you have suprapubic pressure. These are your first line maneuvers. Then you have the second line maneuvers. This is enter the rotational maneuvers. In this, you have Rubens and Woodcock screw. Rubens may or adducting the arm, reducing the biacromial diameter. Woodcock screw is you're trying to rotate the baby by 180 degrees. R is remove the posterior arm. The second R is roll on all fours. That is the Gaskin maneuver. Okay. Then you have the third line or the last resort maneuvers. You have Zavanelli. Okay. You have symphysiotomy. And you have cleidotomy. Okay. So Nishita, no cesarean section में time लगेगा बच्चे to shift the patient to the OT, to give anesthesia, do a cesarean. Minimum to minimum आपको 15 minutes चाहिए, तब तक the baby is going to die. You have only seconds, remember, seconds to take this baby out. Okay. Yes, it is really done. The last two are done. Okay. I have heard of many stories where it has been done. I have never seen, but I've definitely heard of them being done. Now coming to two more important short topics, transverse lie and cord prolapse. Transverse lie क्या है? Baby ऐसा है, ठीक है? अब इसमें क्या problem हो सकता है? If the patient goes into labor with the baby like this, what can happen? There is a very high risk of what happening? Of which complication happening? Of not rupture, cord prolapse. Very good. कॉर्ड प्रोलैप्स हो जाएगा और एक और चीज प्रोलैप्स हो सकता है. और क्या प्रोलैप्स हो सकता है? The hand can prolapse. The cord can prolapse, leading to distress, and the hand can prolapse, And if the hand prolapses like this, okay, I don't know how many of you have seen this situation in the labor room. Rural areas में बहुत commonly तो नहीं, but कभी ना कभी देखा ही दिख जाता है. The hand has come out. So once the hand comes out, what is this called? So in transverse lie, the presentation is a shoulder presentation, right? This is the shoulder is the presenting part. So this is actually called a neglected shoulder. So shoulder dystocia and neglected shoulder are different things. दोनों में confuse नहीं होना है. Shoulder dystocia is head comes out, shoulder is stuck. Neglected shoulder is a shoulder presentation with a hand prolapse. ठीक है? So this is going to result in what? So that you can see what's happening. It's actually shown here in this picture. The upper segment is contracting. It's trying to push the baby out. The lower segment has become very thin and very stretched out. So basically, this is a patient in obstructed labor. Eventually, what's going to happen? And can you see ये जो red यहाँ पे दिख रहा है? Red क्या है ये? What ring is this called? This is called as Bandel's ring. You must have heard of Bandel ring. Is a ring which is clinically seen on the abdomen between the upper segment and the lower segment. It is a feature of obstructed labor. Now, what's going to happen? अगर ये obstruction release ना करो, if you don't do an emergency cesarean section, very good, Jigar, this is going to lead to either a rupture uterus. This is what will commonly happen in a multigravida, or it will lead to uterine inertia. The uterus will just get tired and stop contracting. ठीक है? So it will lead to either a rupture uterus, which is a common scenario in a multi. In a primigravida, what is going to happen? Uterine inertia happens. Why obstructed labor? Because ये बच्चा बाहर कैसे आएगा? You are pushing something through a narrow opening and वो out नहीं हो सकता है. कैसे बच्चा निकलेगा? It can never come out, है ना? It's a transverse lie. So this is called an obstruction, right? So this is obstructed labor. So remember these terminologies. These are buzzwords for transverse lie: neglected shoulder, hand prolapse, and cord prolapse. If the membranes rupture, cord prolapse will happen, and there is no mechanism of labor. So you have to do a cesarean section, even if the baby is dead. Cesarean section is the rule. There is no other way. Cesarean section ही करना है इसका. ठीक है? बच्चे ज़ैवनेली नहीं है. ज़ैवनेली इज पुशिंग द हेड बैक. इसमें आप हाथ वापस नहीं डाल सकते हो. ठीक है? ज़ैवनेली इज डिफरेंट, दिस इज डिफरेंट. डोंट गेट कंफ्यूज्ड. ओके. Now, what will you do? So this is what can happen if the patient goes into labor, what we are worried about. We don't want this patient to go into labor. So at 37 weeks, what should you do? You should plan an elective LSCS. But if the patient comes to you before, say she's come to you at 36 to 37 weeks, like in breech, you can also offer her an external cephalic version. Otherwise, you do an elective LSCS at 37 weeks. मैंने लिखा है यहाँ पे मल्टी ग्रेविडा में रप्चर यूट्रस के चांसेस ज्यादा होते हैं, और प्राइमरी ग्रेविडा में यूट्राइन इनर्शिया, द यूट्रस स्टॉप्स कंट्रैक्टिंग. So management is an external cephalic version at 36 to 37 weeks, and elective LSCS. Otherwise, do an elective LSCS at 37 weeks. There is no waiting beyond 37, because जैसे ये patient labor में जाएगी या जैसे ही membranes rupture होंगे, either the cord will prolapse or the hand will prolapse, or she will go into obstructed labor. So you don't want any of these horror situations happening. ठीक है? Now coming to cord prolapse. Cord prolapse is also an important short topic. ठीक है? Cord prolapse में क्या हो रहा है? You can see that the cord has slipped through the cervix. Now, why is this a dangerous situation for the baby? This is a dangerous situation because once the cord has come out, it gets compressed. It gets compressed between the fetal head or the presenting part and the maternal tissue. So it occludes the blood vessels in the cord and the baby gets hypoxic. and it gets hypoxic very, very quickly. So cord prolapse is an emergency situation because it can lead to fetal hypoxia and fetal death. So cord prolapse, we say once the cord has come outside the ruptured membranes. Membranes have ruptured, cord bahar aa gaya. Agar membranes intact hai, sometimes rarely when you're doing an ultrasound, what happens? You see on the ultrasound that यहाँ पे बेबी का हेड है एंड आपको कुछ नीचे दिख रहा है, हेड के नीचे कुछ अजीब सा दिख रहा है. If you switch on the Doppler, you find vascularity here. So what is this situation? This is a situation of cord presentation. That means the patient is not in labor. Membranes haven't ruptured. Routine ultrasound पे आप कर रहे हो and you find cord presentation. The umbilical cord is lying ahead of the head. So it's not cephalic presentation. The cord is the presenting part. So it's a cord presentation. So if you diagnose cord presentation at term, what should you do? You should immediately do a cesarean section. There is no waiting at all. Immediately admit and do a cesarean section. This is not velamentous बच्चे. I am talking about cord presentation. ये जो umbilical cord है यहाँ पे है ना? And this is the patient who is not in labor, who is 37 weeks. She is not in labor. On ultrasound, you have found that the cord is lying in front of the head. So when you do, when you've done the scan and you diagnose this, what is going to happen if this patient goes into labor? If she goes into labor and the membranes rupture, she's going to have cord prolapse. You're preventing cord prolapse. You've detected cord presentation and you can easily prevent the prolapse. Similarly, if this patient comes in labor before the membranes have ruptured and you do a PV, she says she's 3 centimeter, 4 centimeters, membranes haven't ruptured. आपको यहाँ पे कुछ feel हो रहा है, कुछ अजीब सा feel हो रहा है. क्या feeling आती है इसकी? This came in INI last, I think May only. This gives a bag of worms appearance. So feeling. When you do a PV through the membranes, you feel bag of worms. This is a cord. So what should you do again? Again, you do a emergency cesarean because if this membrane ruptures, you are going to end up with a cord prolapse. So whether you see the cord presentation on ultrasound or whether you feel the bag of worms through the intact membranes, the next thing you're going to do is an emergency cesarean section. ठीक है? But suppose you fail to detect this, आपने ARM किया and cord has prolapsed. ठीक है? Once the is a bit बच्चे vasa previa is different. Vasa previa is when fetal vessels in the membrane, amniotic membrane get ruptured. यहाँ पे क्या हो रहा है? यहाँ पे the cord has prolapsed. There is no bleeding here. The vasa previa mein there is bleeding. Blood vessels get damaged. यहाँ पे the umbilical cord has come outside of the cervix. And because of that, it gets compressed and there is fetal distress. ठीक है? बच्चे आशुतोष, bag of worms is a clinical finding. You don't need to confirm it by ultrasound, but you can only feel it during labor when the cervix is open. Closed os में आपको feel नहीं होगा. It is felt only during labor when the os is open. Okay, ultrasound पे you can make out even when the os is closed. ठीक है ना? How will you diagnose cord prolapse? You have a patient who is in labor, okay, and you find the fetal heart rate is going down, sudden fetal distress. So sudden fetal distress in a patient who has gone in labor. Can you see the fetal heart rate was here? Suddenly drop हो गया. ठीक है, acute fetal bradycardia, very good. So this is the one what you will see on the CTG. So you can get a clinical situation that a patient is in labor, okay, ARM was done and the CTG shows this. Okay, so what is a probable diagnosis? A probable diagnosis is one could be abruption, the other could be cord prolapse. Following ARM, looking at this kind of picture, it could be a cord prolapse, it could even be an abruption. नाउ सो सडन फीटल डिस्ट्रेस हो गया, आपने पीवी किया, आपको कॉर्ड फील हो गया, what will you do next? So what is the immediate thing that you need to do? The first thing is you need to confirm ki baby is alive na. If the fetal heart rate is there, even if bradycardia, if the baby is alive, immediately shift her for a cesarean section. Immediately shift her for a cesarean section, but that will take at least 10 to 15 minutes still. Okay. So in those 10 to 15 minutes, what should you do? You have to try to relieve pressure on the cord. Okay, so जितना आप time दे रहे हो for shifting the patient, calling the anesthetist, getting the stretcher, taking consent, shifting the patient, utne time mein one person should be focused on relieving pressure on the cord. So what should you do? How can you relieve pressure on the cord? How will you differentiate? बच्चे, I just told you, अगर ये वाला picture है तो आप पीवी करोगे, अगर आपको कॉर्ड फील हो गया तो कॉर्ड प्रोलैप्स है, अगर कॉर्ड फील नहीं हुआ, ब्लीडिंग आ रहा है तो एब्रप्शन हुआ ना, एब्रप्शन में यू विल सी ब्लड एंड देयर विल बी पेन. So your immediate next goal is to relieve pressure on the cord. How can you relieve pressure on the cord? But to diagnose, when you do a PV, you will feel the cord or you will see the cord immediately, then take your hand out. You won't keep touching the cord. No, you will have to diagnose it somehow. Diagnosis बन गया, उसके बाद cord को touch नहीं करोगे ना. So relieve pressure on the cord. How? You can fill the bladder with a Foley's catheter. Doing a PV, lift the head or the presenting part ताकि वो cord को compress ना करे. Lift the presenting part up. Put the patient in Trendelenburg. That means head low position. Okay, she's like this. Put her in head low position. This will lift the presenting part upper and relieve pressure of the cord. Roll her onto the left lateral or the knee chest position. Okay, so make her go on the side or roll her over completely. You can even give trocholysis. The best drug we can give, which will stop the contractions for some time, is terbutaline 0.25 milligrams subcutaneous injection. Okay, so you're going to relieve pressure on the cord. Filling the bladder is going to push the presenting part away. A full bladder doesn't let the presenting part come down. Okay, or you manually with your finger lift the presenting part up. Put the patient in such a position जिससे cord पे pressure कम हो, जैसे Trendelenburg, knee chest position, left lateral. So you don't have to do all of these. One or two of these you need to do while you're shifting the patient for a cesarean section. Okay, you can give any trocholysis, but I'm just telling you what is commonly given. Then, very importantly, don't keep touching the cord because you're very tempted कि cord को उठा के मैं अंदर रख दूं. But don't do that because any touch on the cord will lead to further vasospasm and further fetal hypoxia. So don't handle the cord. Try to push the presenting part away from the cord without touching the cord. Okay? So that's what you do in cord prolapse. Two main things. Delivery should be quickly, and while buying time for delivery, try to push the cord, try to push the presenting part or relieve pressure away from the cord. If the cord is outside the vagina, same thing, Soumya. Many times it is outside the vagina, दिख रहा होता है. So don't handle it. Just try to fill the bladder or make the patient in head low. किसी तरह से pressure away from the cord. Now arrange the following maneuvers in the correct order in a shoulder dystocia. What will you do first? McRoberts, Rubens, Gaskin, and lastly Zavanelli. है ना? 4, 3, 2, 1. Correct. A midwife is examining a pregnant woman in labor when she noticed that the cord has prolapsed. What should be the next immediate step? Should she gently replace the cord in the vagina? No. Should she inform the doctor and shift to OT? Yes. But let's see if a better option is there. Put her in Trendelenburg? Also, yes. So she should immediately try to relieve pressure of the cord while simultaneously arranging for the OT. So this is a better option because she's a midwife. the best thing she should do is try to relieve pressure of the cord. Okay. And this is not going to help in any way. Okay. So put her in Trendelenburg and then probably inform the doctor and shift the patient to the OT. Full bladder won't compress the cord. Full bladder will push the presenting part away from the cord. During normal delivery, if you encounter shoulder dystocia, what is the next best step? Will you do a you'll do Mac-Roberts maneuver, है ना? This is Mac-Roberts. Okay. A 34-year-old G2P1 presents at 35 weeks. She has no complaints and is appreciating fetal movements well. She had a previous classical cesarean at 25 weeks for eclampsia and severe fetal growth restriction. She is currently on low-dose aspirin and prenatal vitamins. On examination, the uterus is 38 centimeters in fundalite. Fetal heart is good. An ultrasound reveals a single live fetus in breech presentation. Placenta is posterior, amniotic fluid normal. The patient desires a vaginal delivery. What is the best management? Will you allow her to have a vaginal delivery even if she desires it? No. Okay, so she has a previous classical. If she was a previous LSCS, then probably an ECV would be the best option, but she has a previous classical. This is an absolute contraindication to a vaginal delivery. So you are going to tell the patient ki kuch nahi, we are doing a cesarean section for you. That is the safest. Even if you desire a vaginal delivery, sadly that cannot be done. Okay? So schedule an elective LSCS at 37 weeks. This is an absolute contraindication for a vaginal delivery. Hence, it is a contraindication for an external cephalic version. Okay? In cord prolapse, if the fetus is dead, तो फिर कुछ करना ही नहीं ना, तो फिर तो उसको normally deliver करो. Then why do you want to do a cesarean? The reason for doing a cesarean section, Astha, is to quickly take out the distressed baby. If the baby is dead, then there's no point. Okay? Yes, correct. This is complicated breach. Why do you want to? But remember, if she was previous LSCS, you can turn the baby. Okay? A multigravida is in second stage of labor since 2 hours with good uterine contractions. On examination, the head is 1/5 palpable, fetal heart is 140. On examination, the cervix is fully dilated. The head is at the ischial spines in right occipitotransverse. Caput plus plus, molding plus plus. So this is a situation of deep transverse arrest. She's a multigravida, but there is caput plus plus, molding plus plus. She's going into obstruction. So emergency LSCS is better. Okay, remember if caput molding nahi hota, then vacuum would have been a better option. But also remember that head is 1/5 palpable. A golden rule of applying a forceps and vacuum. This is a golden rule, is the head should not be palpable per abdomen. On abdominal exam, to apply a forceps or a vacuum, please remember this point. Okay, to apply a forceps or a vacuum, the head should not be palpable on abdominal exam. So even if this was caput 0, molding 0 नहीं था, तब भी आप वैक्यूम के लिए ये बहुत हाई हेड है. You should not apply a vacuum so high. So here still would remain emergency cesarean section. ठीक है? A partogram of a woman in labor is shown below. Oxytocin, this was NEET PG last year question. That's why I'm saying they are still asking questions on this partograph. Let's read the question. A partograph of a woman in labor is shown below. Oxytocin infusion has been administered. Mark the best management for this patient. So let's see what's happening here. You can see the fetal heart rate is dropping, है ना? So there is fetal distress, fetus reached 100. And there is meconium also. M means meconium. B means blood. So पहले blood भी था, अब meconium आ गया. Molding is 2+. Okay, what else is given? You can see it's crossed the alert line, ठीक है, but यहाँ पे contractions improve हुए. You can see यहाँ पे contractions were 3 contractions. Now there are 4 contractions, and at this point, the patient has now become fully dilated. So she is fully dilated, है ना? But look at the other thing, look at the descent of the head. The head has not come down. It is still 3/5 palpable. So you have a situation where the patient is fully dilated, fetal distress is there, the head is very high, 3/5 palpable. What do you want to do? Okay, we don't know what it could be, CPD, we don't know what it is, but we know that she is fully dilated. Now, at full dilatation, you can do a forceps, you can do a vacuum, you can do a cesarean. Amongst these three, which will you prefer? Yes, you will prefer a cesarean section because it is too high for a vacuum or a forceps. I just told you, what did I tell you? Ki a forceps or a vacuum can be applied when the head is not palpable per abdomen. It's too high for applying a forceps or vacuum. You will not be successful. You have to do a cesarean section. Okay. So now we are left with mainly PPH. Okay. Do you want to continue or do you want to stop? It's a half an hour to 45 minutes topic. 45 minutes topic. Stop, continue, stop, continue. Okay. Okay. Okay, so lot of confusion. I think we can continue, okay, with mainly PPH. ठीक है, 11:45 तक I will be done. ठीक है, no. Okay, let's finish it because I think we're in the mode. Itna time nahi lagega. It's a quick, easy topic. It's not a difficult topic. It's just an important topic. I know it's a little heavy. We'll make it easy. We won't cover the other complications. जो uterine inversion है, amniotic fluid embolism है, वो एक slide के topics है. वो हम END में cover करेंगे. But let's finish postpartum hemorrhage. इतना time नहीं लगाऊंगे, promise. ठीक है? ये वाले हम नहीं कवर कर रहे हैं, ये हम END में कवर करेंगे because they are single slide topics. But let's cover the main bulk. I promise you I'll finish it very quickly. No break. Let's finish it off. ठीक है? So postpartum hemorrhage is important because it is one of the most common causes of maternal mortality in India. I told you if I have to give you 3 topics before the exam, it is hypertension, antepartum hemorrhage and postpartum hemorrhage. ठीक है? So you have 2 types of postpartum hemorrhage. So if there is excessive bleeding within 24 hours of delivery, it is primary postpartum hemorrhage. If it is after 24 hours of delivery, it is secondary postpartum hemorrhage. ठीक है, I'm sorry for those who didn't want to continue, but थोड़ा सा और just bear with me and we'll finish. ठीक है, if you guys are tired, think about me. My throat now, I can feel that my throat, the mucosa is getting peeled off. I can actually feel it. So I'm going to give a good voice rest for the next 4 days, but just bear with me. Okay. So primary postpartum hemorrhage, I know many faculty continue till 1 a.m., but I don't want to stretch it to such an extent कि आप लोगों को समझ ना आए just because I have to finish the course. है ना? Course I will finish. That is my guarantee. Even if we have to take a few extra hours, so don't worry about that. But I just want to finish this important topic. Okay. So primary PPH is our main focus. And we all know the causes of primary PPH are the 4 T's. What are the 4 T's? 80% of primary PPH is because of an atonic uterus. What happens after delivery? The uterus contracts. When the uterus contracts, I think you all have heard of the living ligature. वो क्या होता है कि जो vessels होते हैं myometrium में, they are interlaced between the myometrial fibers. So when the myometrial fibers contract, the vessels get occluded. है ना? This is called interlacing network of myometrial fibers. But if the uterus is not contracting, the bleeding will persist. So 80% of cause of PPH is atonic PPH. Okay. Next cause is trauma. Trauma means a laceration, cervical laceration, vaginal tear, rupture uterus, vulval hematoma. All these come under traumatic PPH. ठीक है? Tissue क्या है? Tissue is when a bit of the placenta gets retained. For example, a succensurate lobe of placenta or a cotyledon gets left behind. That is retained placenta. And then you have thrombin. Thrombin क्या है? For example, the patient has a coagulopathy. She's a known case of ITP or thrombocytopenia or HELP syndrome where there's thrombocytopenia. So you have thrombin as a cause. So you have the 4 T's of postpartum hemorrhage. Okay. Now, what do you do? The most important question that comes is management of PPH. Is there a lag? Somebody is saying there's a lag. No lag. Okay. So there's no lag. Sorry. Okay. So what do you do when there is PPH? You have to, of course, resuscitate the patient. You have to arrange blood, start IV crystalloids. But if there is atonic PPH, the first initial, how do you know it's atonic PPH? The uterus is not contracted and she's bleeding. If the uterus is contracted and she's bleeding, you have to look for causes of traumatic PPH. But let us discuss the most important one, that is atonic PPH. So in atonic PPH, two things will go hand in hand. One is medical management and the second is mechanical methods of management. These two things go hand in hand. मेडिकल मैनेजमेंट में क्या आता है? द यूट्रोटोनिक ड्रग्स. And which यूट्रोटोनिक drugs are given for management of atonic PPH? The first, of course, is oxytocin. Okay, here we can give large doses. For AMTSL, I told you 10 units. For treatment, you can go up till 40 international units as an IV infusion, not directly. Directly, we can give 10 units. But for treatment, we can go up till 40 international units. Webber, yes, infection can cause, but it is the cause of, usually a cause of secondary PPH. But you're right, infection, if there is chorioamnionitis, that can lead to atonic PPH. An infected uterus will not contract. So infection can cause atonicity. When later on infection, puerperal sepsis can cause secondary PPH. Okay. Now, what's the other drug you can give? You can give prostodin or carboprost. And this is PGF2 alpha. Okay. Now, what you should remember about this drug is the contraindication. Two important contraindication is asthma and cardiac disease, or especially patient with cardiac arrhythmia. This is very commonly asked as a question. Asthma is asthmatics. You should not be giving prostagin or carboprost. Okay. What are the other drugs? You can give methergin. Okay. What else can you give? You can give misoprostol. Okay. And apart from utrotonics, you can also give another drug which should be given, in fact, that is tranexamic acid. What is tranexamic acid? It is an antifibrinolytic. And this has been very recently come in the WHO recommendation that you should give correct, labetalol also should not be given in this. Tranexamic acid should be given 1 gram, okay, IV within 3 hours of PPH, okay, and a dose can be repeated after 30 minutes. Same dose can be repeated if required after 30 minutes. This is something new which the WHO now recommends. Also remember, tranexamic acid is not only for atonic PPH, it can be used for any cause of PPH. It is helpful in traumatic PPH also. Okay, so tranexamic acid can be given as in any type of PPH. Okay. Can I please repeat tranexamic acid? So tranexamic acid 1 gram IV within 3 hours of birth, it should be given. Okay, if a patient is bleeding, and a repeat dose can be given after 30 minutes. It's not a uterotonic, it's not going to contract the uterus, but it helps in coagulation, okay, of blood and stoppage of bleeding. It can be given in any type of BPH. Okay, so this is important. Dose of carboprost, if you want to remember, it is 250 microgram. Okay, the more than the dose, the route is important. I forgot the route. The route is intramuscular, okay, or intramyometrial. At the time of cesarean section, if bleeding is happening, you can directly inject inside the myometrial tissue. So the route is important. Intramuscular or intramyometrial. Okay, it should never be given intravenous. It can lead to sudden cardiac arrest. Okay. So this is the medical treatment. Now, when it comes to mechanical measures to control PPH, atonic PPH, so mechanical and medical go hand in hand. Mechanical helps till the time the medical management acts. Mechanical also helps when you're shifting the patient from a lower center to a higher center. In mechanical, you have several methods. One is bimanual uterine compression, that is compressing or sandwiching the uterus. Compression. Sandwiching the uterus, you make a fist, put it in the vagina, and with your hand above per abdomen, you sandwich the uterus between your hands. Okay, so bimanual uterine compression, then external aortic compression. This can also be done. Okay, then you can also do uterine massage and help the uterus contract. Then the things which are asked nowadays, one is intrauterine balloon tamponade. Okay, and this is done with several things. I'll show you the images there in the later slides, but the the uh the balloon tamponade mechanism specifically made for this purpose is called the Bakri tube. If you don't have the Bakri tube, you can use a Sengstaken Blackmore tube, which we use in esophageal varices. And Indian people have nicely done the condom catheter can be made. A condom can be made into a balloon tamponade sort of structure. And each of them, basically, what you do once you put this inside the uterus, you instill 300 to 500 ml of saline or ringer lactate or basically any fluid to distend the uterus, and this stops the bleeding, but temporarily. Usually you have to then, so it's basically temporary till the time medical methods act or till the time you shift the patient to the OT. Okay. Then what else? Nowadays we use even intrauterine suction catheters or suction cannulas. What are these? This is something which is even newer. Okay. These are now being proposed more commonly. The government of India recommends these. Okay. So these are invented by Indians. You also now have the Americans coming out with these suction cannulas. I'll show you pictures of them, Abhi. So you put these suction cannulas inside the uterus. They're big, fat metal cannulas, and you attach them to a suction machine, and that suction machine causes the uterus to compress over the cannula, and that stops the bleeding. Yes, correct. Panicker cannula. So in India, two obstetricians have invented this, Samarth Ram and the Panicker cannula. And in the US, this is available as the JADA system. Again, important from the INI point of view. It won't cause perforation. I'll show you the picture. I've used this recently. I've used this for a few cases. It works very, very, very well. Have never had a better outcome. I mean, it helps you avoid surgical intervention for PPH. It works very, very well. Okay. Now, apart from these, and I'll show you these pictures also, but apart from medical and mechanical measures, if these fail, then you move on to surgical methods, which I will just tell you. But also, you should know something new in PPH. that the Federation of International Gynecologists and Obstetricians have said that in low resource settings, in primary healthcare centers, you have divided, basically, you have what is called as PPH care bundles. What should be the initial things that you're doing, especially if you're in a low resource settings with limited things available to you? They say the first is the first response. सबसे पहले क्या करना चाहिए? PPH हो रहा है, atonic PPH हो रहा है, क्या करना चाहिए? Start giving the drugs, utrotonic drugs. Initial resuscitation while you are waiting for blood and blood products. Initial resuscitation should be by crystalloids. This has come as a question already in the INI. Is it colloids? Is it crystalloids? What should you give? You should give crystalloids. Tranexamic acid in the dose I told you should be given, and start uterine massage. So these four are the first response PPH bundle. Give the uterotonic drugs, give tranexamic acid, start crystalloids and uterine massage. Then comes the second bundle. What is the second bundle? Second bundle is response to refractory PPH. मतलब इससे भी bleeding continue हो रहा है, फिर क्या करना है? Then you have to initiate the response to refractory PPH bundle. That is compressive methods, either aortic compression or bimanual uterine compression or intrauterine balloon tamponade. And there's something else called a non-pneumatic anti-shock garment. You must have heard of this. So this is basically you wrap the patient in this garment, and this recirculates the blood and prevents the patient from going into shock. This is very useful when you are shifting the patient to a higher center. Okay, so it prevents the patient from going into shock early and reduces the amount of bleeding also. So compressive measures, balloon tamponade and non-pneumatic anti-shock garment are the response to refractory PPH bundle. Of course, at the same time, you are making arrangements so the patient can be shifted to a higher center. But remember this word, bundles. Bundles अगर एग्जाम में आता है तो confuse नहीं होना. एक first response bundle है and second response to refractory PPH. I wrote shifting. When you're shifting the patient to a higher center, this non-pneumatic anti-shock garment prevents the patient from going into shock. So these are some pictures which you should know. These can come as image-based questions. This is bimanual uterine compression. This is the different intrauterine tamponades you can use. The common ones we use, the second one you should be able to identify. This is the Bakri tube. Okay, this is the Sengstaken Blackmore tube, and this is the condom catheter. These are the three most common ones we use in practice. Bakri tube, the actual Bakri जो इसके लिए बना हुआ है, ये expensive है काफी. It costs 5,000 rupees. So many people don't even keep it in their setups. They keep a condom catheter पहले से ही बना के रख लो. It makes a lot of sense. It's cheaper to use a condom catheter. ठीक है. All of them need to be inflated with about 300 to 500 ml of saline or whatever fluid is available. This can also come as an image-based question. This is the anti-shock garment in which the patient, this is usually used when you're referring a patient to a higher center. This is external aortic compression. Okay, and this is what I was telling you. This is the suction cannula. So you put this is the JADA system by the Americans. So you have this flexible rubber ring which you put inside, and this has holes here. Okay, when you switch on the suction, the uterus gets compressed over this system and it remains contracted like this. In India, we use the Panicker or the Samarthram cannula. These are large, big metal cannulas. We all have these now in our labor rooms. They are very, very useful. It's very easy to do also. Just insert the suction cannula, not all the way till the fundus, so that avoids perforation. Okay, and then you switch it on, and the uterus nicely contracts over the cannula. You many times, so I have done this. After half an hour, you remove this and you find that the bleeding also stops. Okay. Mullerian normally per se won't cause PPH, Asta. Okay. there is no such thing as best mechanical method. It all depends on what you have at hand and what you are most experienced in using. Another important newer concept is the obstetric shock index. You should know what is the definition. It is defined as heart rate or pulse rate divided by the systolic blood pressure. Okay? And the value, normal value in pregnancy is 0.7 to 0.9. A value above 1, okay, predicts adverse clinical outcome. So a value above 1 predicts adverse clinical outcome. So these are the things you should remember. The formula, pulse rate divided by systolic blood pressure. Normal value is 0.7 to 0.9. More than 1 indicates a adverse clinical outcome. Somebody wanted to see the previous slide here. कुछ लिखा नहीं मैंने इसमें, nothing is there. Now coming to surgical management. So if mechanical and medical management fails, the next thing you do is now you take the patient to operation theater. And operation theater may you decide what to do depending on how bad the patient is. If she is hemodynamically stable, you can go in this stepwise flow. But if the patient is very much in shock, you can decide to skip some steps and directly do a hysterectomy. But this is what we usually follow. We first try the compression sutures. These are called as compression sutures. The one you're seeing here is the B. Lynch suture. This is the B. Lynch suture, also called the vertical brace suture. This is usually applied at the time of a cesarean section. ठीक है, तो you can see cesarean section का scar है, तो उसके through हम ये stitches लेते हैं. ठीक है, and it looks like this at the end, and then in the end you've closed the cesarean scar also. But if you're doing this following a normal delivery, or you take the patient to the operation theater, then you can directly, so this is a B. Lynch, which is usually done at the time of a cesarean. So cesarean ke time, if PPH starts happening, you can put this in this type of compression suture. This is the Hayman suture. This you can see there is no incision on the uterus. So this is following a normal delivery. It's the same as a B. Lynch, but without this incision. So this is usually following a normal delivery. We can put the Hayman suture, and these are Cho's square sutures. So these are multiple square sutures which multiple ones can be put, and this compresses different parts of the uterus. You got a chance to see this? Good, Richa. I have recently put up a video on my Instagram where I've done a B. Lynch for a patient with placenta previa. So you can see that also if you follow me on Instagram. Okay, so it will not affect future pregnancy. These are absorbable sutures. So after a few weeks to months, they will get absorbed. Okay, so these are B. Lynch. So this is B. Lynch, this is Hayman, this is Cho's. बी लिंच और हेमैन में क्या डिफरेंस है? बी लिंच में सिजेरियन इंसिजन दिख रहा है, हेमैन में देयर इज नो सिजेरियन incision. ठीक है, now if this fails, if B. Lynch fails, or if you decide that B. Lynch may not be enough, you can directly even do devascularization. What is this? You ligate the different, or you devascularize the different. Yes, you can do B. Lynch in placenta previa also. Okay, you devascularize the uterus. How do you do that? You cut off the blood supply. So what is the blood supply of the uterus? The first thing we do, we do a bilateral uterine artery ligation. So the first vessel we ligate to stop the bleeding is bilateral uterine arteries. If this doesn't stop the bleeding, you put a suture here. What is this? This is the anastomosis of the ovarian artery and the uterine artery. So utero-ovarian anastomosis. So the first artery we devascularize, and you have to do it on both the sides, is the uterine artery, then the utero-ovarian anastomosis. And if still the bleeding persists, the best artery to ligate is the anterior division of the internal iliac artery, again bilateral. Okay, so this is the internal iliac artery. It gives off an anterior division and a posterior division. The anterior division has to be ligated, and this reduces the pulse pressure in that vessel by up till 80%. So this will significantly reduce the amount of bleeding. So if you look at the anatomy, this is the aorta. The aorta divides into two common iliac arteries. The common iliac is going to divide into an internal iliac and an external iliac. This is the external iliac, this is internal iliac. The, the external iliac continues as the femoral artery, and the internal iliac will give off a posterior division, and then it will have an anterior division. The anterior division gives off many branches, out of which one is the uterine artery. Okay, so when you're doing an internal iliac artery ligation, it has to be here. After the posterior division is given off, then you ligate the anterior division. Okay, so this is what you do. Uterine artery, uterovarian anastomosis, and then internal iliac artery ligation. Previous slide, yellow. Okay, if this also fails, then the last resort is you're going to do a hysterectomy. So that's the last resort, is doing a hysterectomy, and obstetric hysterectomy. Okay. So last resort is hysterectomy, but if the patient is hemodynamically stable, another non-invasive or non-surgical intervention that can be tried is a uterine artery embolization. Because uterine artery embolization can be tried in a patient, but she has to be hemodynamically stable for this procedure. This will avoid a surgical procedure. Okay. Now, this is just to end the topic of PPH. The WHO recommendations for treatment of PPH you should know. The WHO says that IV oxytocin is the drug of choice. The other drugs I have mentioned, it is prostadine, methergine, misoprostol. ठीक है, remember carbitocin इसमें नहीं आता. Carbitocin is only for prophylaxis. ठीक है. Then crystalloids is the initial fluid of resuscitation, should always be crystalloids. Tranexamic acid 1 gram IV over 10 minutes within 3 hours of birth can be repeated in 30 minutes. Then mechanical methods are uterine massage, intrauterine balloon tamponade. But remember, these are temporary methods. Okay? If these fail, then you go to surgical methods. Apart from this, you should know the PPH bundles, the first response bundle and the response to refractory PPH bundle. Why is it called obstetric hysterectomy? Because you're doing it in the setting of obstetrics. Normally, we do hysterectomy for gynae causes. Now, very rarely we have to resort to doing an obstetric hysterectomy. That's why it's called an obstetric hysterectomy. So let's end the class here. Methergine contraindicated in hypertensive and heart disease, yes. Yeah, we don't do one medical, one mechanical. We do multiple medical, multiple mechanical methods. We have to see what stops the bleeding, do everything possible to stop the bleeding. So multiple you can give all the uteronic drugs, tranexamic acid, सब कुछ दो. ऐसा नहीं कि एक चीज दे के बैठ जाओ, नहीं, सब कुछ दो. सारे mechanical measures, whatever is at your disposal, do. If that fails, then you go to surgical treatment. ठीक है? So that ends the class. The chota topics that are left, we will cover in END, or let's see how we can cover them. But don't worry, we will cover them. So thank you for having the patience, and listening to me. So now I will see you all after Diwali. So all of you have a very happy Diwali and enjoy. I hope most of you will be with your families, and if not, with your friends. So enjoy the festival. Take a break from padhai, that's also very important. Okay, and I will see you on Sunday, I think, है ना? So good night, thank you. Good night, good night, good night.